Hello, everyone, and thank you for inviting us into your homes tonight for a webinar with the highly talented James Ferrie. Hope everyone is staying warm tonight, as it's certainly chilly in Sydney. James will help to address for you tonight the reasons why not all shockwave therapy devices are the same and the vital questions you need to ask before implementing one, or if you're lucky enough to have one, how you can improve your treatment success. So please feel free to post any questions into the chat box throughout the webinar, and James will answer them at the end of his lecture. The link to download your CPD certificates will be emailed to you in the coming days, so please check your inbox and junk inbox. James, thank you, and over to you.
Thanks, Danny, and thanks everyone for joining us tonight. I'm looking forward to going through tonight's presentation. So what we'd like to achieve at the end of this talk is really to understand the difference between shockwave therapy and Doller class shockwave as well, because not all shockwave devices are created equally. It's a little bit different when we talk about shockwave, and particularly radial shockwave. When we talk about lasers, for example, if you have the same laser, which might be a 1064 laser that delivers 10 watts, you have an apples to apples comparison. Shockwave is not the same between different devices and brands. So not all research can be extrapolated from one device to another. We also want to describe sort of the concept of Doller class and how to incorporate it into your practice as an adjunct therapy, which can really help to improve the success and improve patients' lives when it comes to really chronic debilitating, particularly tendon problems, but also treatment of conditions such as osteoarthritis as well. And I'm also going to talk about some of my ideas in terms of improving the success rate with shockwave therapy that I've picked up over the last decade of using shockwave Doller class in practice. The guided Doller class therapy is basically a new protocol which has been really integrated into EMS's treatment with Doller class, and it's really an all-encompassing protocol to help best manage patients suffering with sort of chronic musculoskeletal pain. And it involves a range of things, looking at the new laser device, high-powered laser device, shockwave Doller class, but also the importance of properly assessing our patients and rehabilitation as part of their overall management. A little bit about myself. So my interests are largely in terms of musculoskeletal medicine and regenerative medicine, and also sonography. And I've done some training in the US at the Interventional Orthobiologic Foundation in ultrasound and fluoroscopy guidance of orthobiologic procedures such as PRP and orthokine and these more injection-based therapies. I'm also proud to be an instructor for Swiss Doller class, because this is something that I use in practice on a daily basis, and it's really made a difference to the way I practice and treat people, and I really enjoy teaching other practitioners some of the things that I've picked up along the way. I've also have a clinic called My Sports Podiatrist, which is really devoted to musculoskeletal injury management. I don't do much general podiatry in there. I mostly treat injuries, musculoskeletal injuries. I'm excited to have 2 clinics. I have one in Ascot Vale in Victoria and another one just opening tomorrow in Docklands, nice and centrally. I also work as an instructor teaching musculoskeletal ultrasound with ZDU down in Melbourne, and I teach point of care ultrasound. So we've had the pleasure of teaching many podiatrists, some doctors, and even some surgeons in the use of MSK ultrasound when it comes to musculoskeletal medicine. If you're thinking about shockwave, or you have a shockwave device at the moment and you're looking for some online training, even if you're onboarding new, if you're a clinic owner and you're onboarding new practitioners, we do offer through EMS education and training. And you can book small group training sessions, and there's a range of us. There's me, a podiatrist, we've got a chiropractor, and we've also got a physio that all have very interesting perspectives. So to cover all the main disciplines that are using shockwave therapy. So when it first comes to Shockwave, I think the biggest question with most modalities is why? Why would you implement this in your practice? And for me, it comes down to it's a non-invasive treatment. And I think that's really important because a lot of patients are seeking out non-invasive methods to treat their sort of chronic pain. It's also validated efficacy. 34 out of the 62 Shockwave studies that are listed in the Pedro database are using an EMS machine. So it's important to use a machine that is validated. As I mentioned before, it's not always an apples to apples comparison when it comes to Shockwave. And we'll talk a little bit more as we go through the presentation. It also increases your treatment options. This doesn't necessarily replace what we do as practitioners. What this does is help to enhance what we do. So the importance of rehabilitation, the importance of your load management in treating these sort of chronic tendon problems is really important. But sometimes, despite doing all the right things, we have a condition that's really stagnant and we're not getting that clinical effect that we want. And in those cases, in those sort of scenarios, patients are often left looking for other options. And it's a non-drug based treatment. And it's also safe and effective. I use this on a daily basis in clinical practice because I get very good results with it. But also in the 10 years that I've used this, I've never had an adverse event using shockwave therapy. Nothing noticeable. Occasionally you'll have the, and I warn patients at the start that sometimes after that second or third treatment, as we're starting to increase the pressure, you can have a bit of a mild flare up in symptoms. And that's sort of completely normal and it will subside with the next session. But nothing more than that. I've never had any bruising or anything else that was a noticeable reason or adverse effect that was a reason for stopping the course of treatment. Also, no surgery. No surgery means no recovery time. No injections means no risk of adverse complications. And even though most musculoskeletal injections are safe, there is always, when you pierce the body, risk of causing damage. And an example is, and I have done in the past many injections and still do for heel pain. And it's a very painful injection to do without anesthetic. So in most cases, I'll use a tibial nerve block. Now, whenever you're injecting around a neurovascular bundle, there is always risk that you could injure the nerve and cause neuropraxia and nerve problems. And this has to be weighed up and the patient needs to be made aware of that. So in using Shockwave, I do very, very little injections because probably 85, 90% of the patients who would otherwise may opt for a cortisone injection or a PRP injection or a prolotherapy injection, they'll get a good clinical response with Doloclass without taking that risk. And also no drugs means you've got no risk of addiction. And this slide I like because what it highlights is, and this is looking at a 5-year follow-up of the eccentric loading protocol for Achilles tendinopathy. And what they looked at was 58 patients looking at 70 tendons. And they followed these patients up over a course of 5 years. And what was interesting is 60% of those patients still had pain. And 48% of them had sought an alternative treatment. The thing is, there could be a whole number of reasons why your treatment may not work. You could set up a perfect rehab protocol, but if the patient isn't compliant or if they have pain whilst they're doing that exercise, it may cause them to stop, prematurely, and you can often lose those patients to follow up. And when it comes to things like Achilles tendinopathy, I don't think sort of operative treatment has and surgery has a large, scope in that area. This is where we want things that are things that are safe, effective, and get our patients back on track. So we're going to recap a little bit on the fundamentals, but there's a few interesting things. So the EMS Doloclass handle has changed a little bit. So it's still uses our Evo technology. So basically the way a shockwave handle works is compressed air from the unit enters the handpiece and it shoots a projectile down a barrel, which makes contact at a very high speed, over 100 k's an hour, with our applicator tip. And this creates a series of radial shock waves. And these shock waves have both a high pressure wave followed by a low pressure. And this is what generates cavitation, which is important for the therapeutic effect. Now, one of the evolutions in the handpiece with EMS was changing to a piston-based technology. And the benefit there is we're able to maintain. So what happens is as the frequency goes up and as we treat at a higher frequency, this projectile has to return back to the start. So the faster it goes, the higher the frequency in terms of the number of shocks per second, that projectile has difficulty making its way back to the starting point. And then because it loses a bit of distance, we lose energy in that. So one of the evolutions is a change in technology, which means that even with EMS, as we increase the frequency, the energy doesn't drop off. The handpiece now also allows you, which is really convenient, to change the pressure from the handpiece, and we can also start that. And the applicator tip I do really like. That sort of spring-loaded applicator tip is sort of unique to the Dollar class Shockwave. And it's really fantastic when it comes to treating myofascial symptoms because it becomes like an extension of your own sort of hand. So if you're a practitioner that does a lot of sort of manual therapy and massage, that applicator tip with the spring loaded is really helpful to sort of get in there, and it gives you a real feel. You can really feel when you're on fascia and you can feel when you're on the right sort of place, and particularly when you're treating things like trigger points and around sort of bony landmarks as well. So in terms of that anatomy of the shockwave, these are the important aspects. What we have is as the projectile sort of hits that applicator tip, we get a compression phase of, and this is where we get a positive energy density. It raises above the atmospheric pressure. That quickly drops off, and then we get this negative energy density. And it's this negative energy density and the difference between it, which is the combination for getting good cavitation. And cavitation is, we'll talk about that in a little bit more time, but this gives us our total energy difference, okay? As we said, we've sort of been through, but this is really what generates our cavitation. And cavitation are small little bubbles that form. And in this case, we're looking at a propeller, and as that propeller spins around, the leading edge causes positive pressure. And then the edge on the other side, we get a negative pressure that forms. And when that negative pressure develops, it changes the boiling temperature of the water effectively. So what these bubbles are is actually water vapor. And then as the energy density, the pressure returns to normal, those little cavitation bubbles implode and create further shock waves. And those shock waves have an effect on terms of the cell membrane and cause various signaling. So the winning sort of combination when it comes to shockwave is having a high energy, and what's consistent across a lot of the literature is that a high energy output equals high cavitation, and this really does give us the best clinical results. And this is a comparison. This is one of EMS's sort of benchmark studies where we're looking at a few different devices, okay? And what we can see is that the cavitation, or those little black bubbles, which are really important in terms of the therapeutic effect, we can see that there is different profiles depending on different machines, different parameters. But we've got all of these devices working at 15 Hertz, meaning there's 15 shocks per second. But we can see quite a different amount of cavitation. And what's important when we're treating at those higher frequencies is with a lot of devices, we can lose a lot of energy, and that's going to have an effect in terms of the clinical result. If we have a little bit of a look here, this is showing some of that benchmark. So what we have a look at, if we have a look at, and this is where I'm talking about in terms of laser, for example, if we have a specific wavelength of light, say, for example, a 1064 nanometer, and we've got two lasers that both produce 10 watts of energy. That's an apples to apples comparison. It doesn't really matter about the brand. The parameters are exactly the same. When it comes to Shockwave, the engineering is different between different devices, and that ultimately affects the energy output at the end. So even though you might be using a device that goes to 5 bar, the differences in compressors has an effect on the amount of energy that's delivered to the patient. And ultimately, that's the important part. So if we have a little bit of a look here, if we look at, say, 4 bar, treating at various different hertz, so we can see the energy density on our graph on this side, and we can look at the frequency on the bottom part. So you can see that when we're treating at basically 1 bar, there's a bit of a difference there. But then as we start to make to sort of 10, we get a significant drop off in terms of some of the competition. And when we're treating up at 15 hertz, there's a huge difference in terms of the energy output. And when we're looking at having a clinical effect, and we know that having a higher energy density is important in terms of the clinical result. And if you're treating at even, say, 10 hertz, we've got a large difference in terms of the amount of energy that's being delivered to the patient. This particular study looked at, this is using Doller class, and it's looking at the dose-related effects for knee osteoarthritis. So in this particular study, they took 89 patients with knee OA, and they were basically divided into 4 different groups. So one, they wanted to explore whether it was the total number of shocks that was important, or whether the energy density was the important factor. So one group got low energy, and we're talking so 0.12 millijoules per centimeter squared. The second group got, and this is just 2,000 shocks delivered. The other group got the same energy, but we just delivered twice the shocks. And then we've got our high energy group, and we've got a 2,000 and a 4,000 impulses. So one, the energy density is the same that we're delivering to the patient. This is treating at 4 bar. In one group, we're doing 2,000 shocks. In the other group, we're doing 4,000 shocks. And this is the difference in terms of, this is our control group that really received no shockwave. We can see a significant drop in our VAS scale, but what's the most important thing is we see a similar drop off when it comes to, we see a big noticeable difference between low energy and high energy. And whether we did increasing number of shocks didn't make too much of a difference. So the biggest factor is the total energy density that's delivered. And on the WOMAC scale as well, we see a similar conclusion there as well, that it really comes down to not so much the total amount of shocks that's delivered, but what's important is the amount of energy that's delivered is correlated with the clinical impact. So we can see that the placebo had limited effect, and we can also see that low energy had limited effect as well. And this is where it gets a bit difficult in the literature to compare apples with apples. So this is a picture looking at our shockwave. So what we can sort of see is as that shockwave propagates, we can see, and this sort of hydrophone is looking at this. So this is in the compressive phase. We've got our positive energy density. And in our second image, we can see as that shockwave propagates, we start to see these little cavitation bubbles, which are these little black dots. And if you have a look closely, you can see some radiating rings that are leaving from that site, and these are the implosions. So as those little cavitation bubbles implode, it causes secondary shock waves, and these have an effect on the cell membrane, which causes the release of various cytokines and neurotransmitters that's important for our clinical effect. In terms of the scale of this is showing cavitation down to sort of 3 to 4 centimeters. So when we're using our radial devices, we're treating conditions that are up to about 4 centimeters. Beyond that, we start needing to look at a focused shockwave that can treat beyond that. But for most clinical conditions that we would see around the foot, the knee, and even the hip, 4 centimeters is often more than sufficient. The new device, basically, one of the differences has always been EMS's devices have had an external compressor, where a lot of the sort of other shockwave devices you'll see, they'll be just the standard unit, and they use an internal compressor inside. Now, the difficulty there is that when you use a small compressor, as the air is being used, the pressure starts to drop off in terms of what's being delivered to the handpiece. So EMS have always used a solid external compressor to make sure that the amount of airflow to the handpiece is always consistent, so that we're always achieving that consistent energy density being delivered to the patient. So the new development is using a dual integrated compressor, which is benchmarked against the larger external compressors. And this is particularly important for a lot of practitioners who are working from multiple sites, because that's always been one of the limitations. People like the results with dollar class, but if you're working from more than one location, it wasn't really feasible to cart around a big, large external compressor, and the unit wasn't very portable. Whereas the new unit, we're using this dual compressor technology, meaning that we get the same benchmark study in terms of energy delivery that we get with a big external compressor that we see in the Swiss Master and also the Smart 20. The smart protocols are really helpful as well, and these are in terms of improving the tolerance of shockwave. The smart protocols allow you to sort of ramp up the amount of energy that you're delivering. So it starts off on a very, very mild and slowly starts to build that pressure up so that the patient tolerates the treatment better. So we use ramp up mode. And what's really good about the new computer system on there is we can actually calculate the total energy that we delivered, because as we change we may change the pressure during the treatment. We always want to try and titrate that pressure up to the maximum that the patient will tolerate. And I'll generally tell patients that, look, this is going to be uncomfortable, but you're in control. We're going to start off on a nice sort of low intensity, and I'm going to gradually work that pressure up. And occasionally when I'm on a particular area, it will be a bit uncomfortable, but after 10 to 15 seconds, that will dissipate. Being able to look at the total energy that you've delivered in the treatment is helpful in terms of consistency, one, between practitioners within the practice, but also in terms of in your own notes, that you can see that you're delivering and you're working and building up that energy density over time. In terms of the mechanism of action with shockwave, it's not fully understood, but we do know that shockwave causes a release and activation of our C fibers, and these release various substances such as substance P, calcitonin gene-related peptide, and nerve growth factor. These neuropeptides and cytokines have an effect in terms of metabolically, in terms of the cellular environment. We also get the release of lubricin, which is really important when we're treating osteoarthritis and conditions that, and lubricin is basically sort of a lubricant that helps things move. So when we're treating some tendon pathologies, but also osteoarthritis, it can help with the lubricating effect inside the joint. These neuropeptides have been shown to activate fibroblasts, mesenchymal stem cells, and osteoblasts as well. So there are multiple hypothesis and current investigation in terms of how exactly shockwave works, but like most things, the mechanism of action is complicated, and ultimately what's important is we know that this technology has been used since EMS developed the first radial shockwave device and patented that in 1999, and this treatment has been used to treat millions of people around the world with a very good safety profile. And we've also got very good evidence when it comes to treating many things like osteoarthritis, Achilles tendinopathy, and plantar fasciitis. The way I describe shockwave to patients is it's a bit like hitting the reset button on your injury. When you've got a chronic tendon problem or plantar fasciopathy, these conditions are often very stubborn. And despite, as clinicians, our best efforts in terms of rehab, load management, orthotics, bracing, all of those things, we do get patients sometimes that just aren't responding to treatment. And sometimes you do have to hit the reset button. And Shockwave is a really useful way to do that. So I'll often tell patients that sometimes, these conditions just get stagnant, and despite everything we do in terms of rehab and load management, it's just not shifting. So Shockwave can be really useful. And it's really good to pre-warn patients. So maybe in the early phase, you might be just prescribing the patient with some exercises, or maybe an orthotic, or advising them in terms of things like footwear and activity. And I'll always tell patients that we do have other tools in our kit. So if this condition isn't getting better, what we'll look at doing is considering some shockwave therapy. And it has a few effects. And the first is that it sort of hits a bit of a reset button in terms of the pain. And this is a bit more like your sort of reset in terms of software. So patients will often feel better straight after their treatment. And I'll tell patients that often this will be a bit uncomfortable while I'm doing it, but you'll stand up and it will feel better. This effect will wane a little bit. So it'll be really good for probably that week. And as we get closer to our next session, that effect will start to drop off a little bit. And then with our next session, we get a little bit more improvement. It'll drop down a little bit. Usually by the time we get to that last session, our 3 to 5 sessions, that's at a point where most of our patients will be sort of sitting at that, 70 to 80% improvement overall. And the remaining improvement is a bit more that sort of hardware. It takes a little bit longer. And this is consistent in the literature that it takes sometimes that 6 to 12 weeks after you finish a course of treatment for the patient to see the maximal clinical effect. And advising the patient and telling them this, and this is a point that I reiterate over and over again, because you do occasionally have patients where even during the course of their therapy and their shockwave, they're not maybe making huge improvements in symptoms. But then you see them, 6 weeks later or 12 weeks later, and there's a marked improvement. So it is important not, if you do 1 or 2 sessions and you haven't had the clinical effect that the patient wants, that the patient's aware that this is a course of treatment. Just like with antibiotics, there's no point taking just 1 or 2 pills. You've got to take the course of antibiotics. This is a course of treatment. So there's no point doing 1 or 2 sessions. So it's important to really communicate effectively with the patient in terms of, 1, what your expectations are, and because if you don't set those expectations in terms of what this treatment will do, where the patient will be at, patients create their own expectations. And then if you don't meet those expectations, in their eyes, you'll have failed. So the biggest thing comes down to communication. Once you've decided that this is the right treatment to go down, most of what you do is communication. So in that first session that I'm doing Shockwave, I will spend 80% of that consultation talking to the patient about Shockwave, talking to them about the expectations, how this works, but also the most important things. 1, my expectation in terms of what I want them to do afterwards, in terms of, after I do this treatment, I don't want you to go out and go for a 15K run tonight because it feels good, because that's going to increase our likelihood of having a flare up. And the tissue just won't be ready for that. The other thing as well is, so I find that that's one of the most important things, is that communication with our patients. That's how you get them to buy in, to follow through in terms of completing their course of treatment. Getting a good result with Shockwave does fundamentally come down to getting the right diagnosis at this first point. Great technology such as Doloclass can't make up for sort of poor diagnostic skills at the start. It's really important that you've got the right. So if you're, for example, if you're treating someone with, say, for example, sometimes as people get older, there's often deterioration in their fatty padding of their heel bone, and they can develop a bit of an acute bursitis and associated with the fact that there's not really good fatty padding underneath it. So if their plantar fascia is otherwise completely normal and their pain is mostly inflammation and inflammatory related to friction bursitis underneath their heel, Shockwave is unlikely to have a significant effect on that patient. So if you've misdiagnosed them as plantar fasciitis, they're likely not going to get to do very well. So it really does come down fundamentally to making sure you've really got the diagnosis right at the first point. In terms of some of the contraindications, anticoagulation therapy. So if a patient has a previous history of, DVT and they're on medications such as warfarin or blood thinners, things like aspirin are okay. But if they're on a stronger, such as warfarin, heparin, and various other anticoagulants, we avoid Shockwave in that case. Pre-ruptured tendons are basically our tendons with significant intrasubstance tearing. These we also avoid treating. We don't treat over lung and gut and spaces in the body that are filled with air, such as our lungs or our gut. So if you're a practitioner who treats a lot of upper limb indications, when you're treating things like, rotator cuff or even the trap muscles, we want to try and aim our Shockwave handle sort of away from the lungs. Pregnancy, again, Shockwave hasn't been shown to be to cause any adverse effects, but in pregnancy we always avoid because it also hasn't been studied in this particular case. So we sort of avoid treating until after they've given birth. Infection and if you've got a local tumor, that makes sense. And infection, we do not want to spread any of those things. So the perfect patient, and this is what's really important. So the perfect patient for Shockwave, I find, is a patient that's had pain for, greater than 3 months generally. And their pain is usually stable and localized. So when you're palpating and clinically assessing them, you can really locate that pain to a specific place. It is the mid portion of the Achilles tendon. It's the plantar fascial insertion or the insertion of the Achilles tendon, the glute insertion to the greater trochanter. If you have a patient that has pain in a lot of places, so this patient comes in with a history of plantar fasciitis, but really everything's sore. It's sore medially, it's sore laterally, it's sore, all over the place. And and you're palpating it and you're having a lot of trouble really locating that pain. These patients don't always get the best outcome when it comes to Shockwave, because I think often their presentation is a little bit more complex than that. They need to have a bit of tolerance to palpation pressure. So if the patient's extremely hypersensitive in that first appointment where you're palpating them and they're really not even tolerating light pressure, you need to get that to sort of settle down before you can implement Shockwave. Because it is we know that you have to be able to deliver a reasonable amount of energy to the tissue to get a good response. And if you're unable to do that because of the patient's tolerance is very low, then that is going to impact your clinical result. One of the changes that EMS have done in releasing the high-powered laser is specifically for that. So high-powered laser has an effect in terms of an analgesic effect that kicks in within 5 minutes. So this is, when combined with Shockwave, can be used for these hypersensitive patients where they're pre-treated with a 3-minute session of laser. We wait 5 minutes and that allows the analgesic effect of the laser to kick in. And then we can use Shockwave and we're able to deliver a higher amount of energy. And there is research to back up that effect, that the patients that were pre-treated with laser were able to reach a higher energy during their treatment. And ultimately, we know this has an effect in terms of patient outcome. And also if the patient, we want a patient that's got a little bit of load tolerance as well. And what I mean by this is if the patient's having a lot of difficulty with really basic, a small walk around the block is enough to really set them off. We need to sort of we need a bit of reasonable load management there. Whereas if you've got a patient who's got, Achilles tendinopathy, it's otherwise sort of very painful in the morning, they're hobbling, it's maybe limiting them from playing tennis, but they're sort of still getting around work all day, it's sore, it's noticeable, but they're sort of managing, those patients will do often really well with Shockwave. So these are some of the things, and this is just sort of a bit of my clinical experience in using Shockwave for the last 10 years. These are the sort of things that I look for in terms of which patients tend to do really well and which patients do we need to often implement a few other things before we get them to the point of Shockwave. Because a patient that might not be a great candidate right this minute for Shockwave, I will often work them up to being a good candidate. And we'll talk about that in a little bit. And these are patients in terms of the patients that I will hesitate before jumping on and doing Shockwave right away. These are patients with unstable pain. They don't really know what's triggering their pain. They may have pain at night. Sometimes it's really sore, and then other times it's, but their pain is really unstable and they have trouble really knowing when it's flaring up and when it's not. Again, if that pain is really poorly located, if you ask them to point to the location where it hurts the most and they sort of point to, the whole thing, it's hard in terms of where do you want to deliver all of your energy. So, yep, we can treat if we're treating the knee, we could treat the patellar tendon, we can also treat myofascially as well. And this is not to say that we don't treat these patients, but I just have a little bit of a different expectation in terms of, because often these are the case where you've got really sort of chronic pain and there can be a little bit more to it in terms of sort of the biopsychosocial considerations in terms of, leading to more of those chronic pain conditions. Again, if the pain is really severe, poorly controlled, and you have a lot of trouble just palpating it lightly, and also if the patient's had repeated cortisone injections, we know this has an effect in terms of that tissue's ability to regenerate, but also multiple cortisone injections in one place will often tell you that really it's probably more complex than just that one target spot. So if you put some, cortisone into the retrocalc bursa, for example, and the patient gets no improvement in their symptoms, even just from the anesthetic, you generally know that you're not working with just that as a primary diagnosis. You need to look a little bit wider in terms of what's causing the patient's clinical problem. Sometimes injections are used for diagnostic purposes. So if the patient hasn't had a response with that, it should lead you to expand your sort of clinical considerations and history and diagnosis. Those patients who might not be a great candidate right this minute, they will often be a good candidate for Shockwave. It all comes down to getting the timing right. So sometimes we'll have a patient who comes in with this sort of acute on chronic presentation where they may have had sort of some chronic heel pain, and then all of a sudden they've had a severe escalation in their symptoms, and they'll come in hobbling. They might not be able to put their heel on the ground. They may complain that it sort of aches a little bit at night. And often when I scan these patients with ultrasound, you'll often see there's some chronic plantar fasciopathy that's present, and they'll often have an intrasubstance tear which is developed. So when you've got chronic plantar fasciopathy or a tendon, tendinosis, that tendon can be at risk of developing an intrasubstance tear because its load capacity is reduced. They may do something that they, don't even think is a lot of load on it, such as mowing the lawns, or have just increased their walking a little bit too far. And then they'll present with this sort of acute flare in pain. Now, these patients I'll often manage in terms of really reducing their load, whether I do this with brace, strapping, and work on that. And it might take me a month or so to get them to the point where that pain's a little bit more stable, and then they'll be a really good candidate. So the same patient who, if I was to treat them in that first session, they may not have either tolerated the treatment very well or not had the best outcome. With that same patient, you can get a really good outcome. It's just about sort of managing them. So as I said, they're the sort of things that I look for in terms of, and this is just, people may have a different perspective to me, but I generally try to get that pain reasonably stable. It can be severe still, but I'll work to get the patient to that point. And we might use things like rehab, as I said, brace, orthotics, shoes, load management, a whole range of things I'll throw at it to get them to that point. Often you might take a few points off their VAS, but they've still got a chronic problem. And that's when Shockwave can really make a marked difference in these patients. It's a little bit like sort of cultivation, I think. So just like farmers need to sort of cultivate the land and prepare it right to get a good yield in their crop, we're a little bit the same. Sometimes with those patients, I will do the work up front to get them to that point where they're going to tolerate and get the best response from Shockwave. Some of the considerations to take into account as well is one, sort of the number of impulses, depending on the location that we're treating. So if I'm treating, for example, the plantar fascia or the Achilles tendon, generally I will do sort of maybe, I want 2,000 shocks delivered pretty much in that main area that you've located in terms of clinical concern. I'll often add 200 to 300 extra shocks, which I use at the very start at a lower intensity. But I want 2,000 that are delivered pretty much at the energy that I want to deliver. So when I'm treating a heel, for example, or plantar fasciitis, what I tend to want my pressure is generally over 3. That's what I aim to get the patient up to. So I'll try and maybe start on that 2 to 2.5 bar, but I ultimately want to get them over 3. If I'm treating below 2.5 bar, I tend to find that for something like plantar fasciopathy, you're not going to get necessarily the best clinical response, because you've got to punch through quite a lot of fatty tissue and thick skin. So you need a bit of energy to do that. In terms of the pressure, we want to try and titrate that pressure up to the maximum that patient will tolerate. We don't want the patient to be uncomfortable in a really significant way. So I will tell the patient, listen, it's going to be uncomfortable. I don't want your pain being sort of more than a 7 out of 10. So it may have little bursts where it gets a little bit higher, but then if you take a few deep breaths, you'll find that will desensitize and that will pass. And that's really important in terms of that education and in terms of setting those expectations with the patient at the start, so they know what to expect and they communicate and work with you when you're doing the treatment. That's how you ultimately get patients to really complete their course of treatment. If you have a patient who comes in with a really sore area and you don't communicate these things effectively, you then put a device that's going to cause discomfort in that area. The patient doesn't know necessarily, hasn't really comprehended what to expect. The likelihood of them coming back for a second session is not very high. That's where that sort of communication is really important. The frequency can also help in terms of pain. So in general, a lower frequency, meaning lower in terms of, say, the lower the number of hertz, say 2, 6 lower hertz compared to, say, 25 hertz, is going to have a little bit more penetration depth. However, the higher frequency can often be really helpful in terms of reducing pain. It desensitizes the area faster and is often tolerated. So if I'm treating an area like an enthesis, like the Achilles tendon insertion, I will often treat at a higher frequency because it's very superficial and I don't necessarily need huge depth. Whereas maybe if I'm treating up around the hip and we've got a bit of adipose over that greater trochanter, I might want a lower frequency just to really maximize penetration. Particularly if there's a bit of sort of padding over that area, you may find the patient doesn't need necessarily that higher frequency in terms of to desensitize things. But definitely if your patient's having some difficulty in tolerating shockwave, the first thing to maybe change is the frequency. And if you increase that frequency, you're able to keep the energy density the same. You're still delivering the same amount of energy to the patient, which we know is important. But if the patient's tolerating it better with the high frequency, that's a little trick that you can use. As I said, that there's a bit of a relationship in terms of when it comes to ultrasound, and it's similar with shockwave as well, that our higher frequency can lose a little bit of punch in terms of depth. as I said, when we're treating really superficial things, this doesn't matter. When we're treating deeper indications, when we want all the depth penetration that we can, that's where it's probably more important to lower that frequency and maybe use 8 to 10 hertz. Muscle tone, when I treat muscles, I'm often using a really high frequency, 25 hertz. And the reason for that is that higher frequency has the ability to overcome the Golgi body, and that has an effect to reduce muscle tone. So Shockwave is also used in things like even stroke in patients with spasticity because it has an effect on muscle tone. And the effect on muscle tone is better with a higher frequency. So some really important things, and these are some things to improve your success and make sure patients are better equipped to complete their course of treatment, is in that first session, don't necessarily start right on that painful place. I'll often start a few centimeters away from it, start on a low intensity, because even the noise, and I'll often sometimes just fire the handpiece just so the patient knows what noise to expect. And then with light pressure on an area that's not necessarily their most tender spot, I will let them feel that sensation. And then they go, okay, that's sort of safe. I get what that feels like. And then you sort of slowly start working onto the painful spot. As I said, I want to deliver 2,000 shocks at a reasonable intensity into my main sort of location. So if the heel I'm treating, I want it into that plantar fascial insertion. I then may often increase and do an extra 1,000 shocks where I'm treating with the larger applicator, where I'm treating maybe the muscles or the mid portion of the plantar fascia. So, but I want to deliver a significant amount of energy to right where it's needed. The same thing goes with, say, treating a hip. If we're treating, say, some greater trochanteric pain syndrome, I'll be doing sort of 2,000 on that place. And then I might add 3,000, an extra 300 where it's really just building up. And then I might do, say, an extra 1,000 shocks, which is more on the muscles, where we're doing a bit of a posterior release on the sort of joint capsule and trigger points through the muscles. As I mentioned, that higher frequency can be helpful in terms of overcoming pain. Using a higher frequency is often tolerated better with patients, and it means that you don't always have to drop the pressure if the patient's having some difficulty tolerating it. And when you're treating things like the insertion of the Achilles tendon, a little trick is to put a big blob of ultrasound gel on there and sit your applicator tip in that gel, but not touching the skin. And what happens is the ultrasound, that shockwave is still able to penetrate through the gel without the applicator tip being on the skin. It's still going to have a therapeutic effect. And you may only need to do that for 20 seconds or so. And then you slowly lower it down onto the skin, and the patient will often have minimal, that they won't notice that shock to start with. When I treat things like the enthesis as well, I'll often use the larger applicator tip. You get really good results with that. If I'm treating the Achilles tendon insertion, I'll use that 36 millimeter applicator tip on the Evo handle. Because if the patient is tolerating that really well, you can always increase the pressure. But we do have a reasonably broad insertion there. Patients tolerate it well, and you still get very good clinical response. It's also really helpful to put to stabilize that limb. I always like to use one hand to sort of stabilize, and I put a little bit of mild traction onto the limb because it does help dampen any of that sort of reverberation. Sometimes when you're doing the treatment, a patient's not experiencing pain in the location you're treating. They're feeling like the vibrations through their ankle, and that's what's uncomfortable. So gripping the area reasonably firm, a little bit of tension really dampens that down, and it often improves the patient tolerance as well. A consent form, even though Shockwave is an extremely safe procedure, and as I said, in 10 years, I haven't had a significant adverse effect, I still like to get patients to sign a consent form. And the main thing with that is that really it does set out, and it makes sure I go over all of the things for the patient to expect, how it works. And it sort of says down there that the patient feels comfortable that it's been properly explained to them, and they don't, do they have any further questions? But it's also explains that it's a course of treatment. They require, between 3 to 6 sessions. So the patient knows everything going in up front. And I think that's really important in terms of making sure they complete their course of treatment. Because if the patient's not committed and doesn't want to go through it, but they maybe just, do on the day, they're likely just not to come back. And it's a bit of a waste. So it's really important that you sit down and spend the time. And as I said, in that consultation where I'm first, in that first session with Shockwave, I would spend 80% of that time just talking and communicating and discussing it with the patient so they really know what to expect. And that really does improve the amount of patients that will complete their course of treatment. I think I went through my books and just had a look at that. I think like 99% of the patients that started Shockwave completed that course. And when it comes to many other treatments like injection therapy and stuff like that, no, a lot of patients aren't coming back for that second injection. If you've ever heard a patient who's had an injection, a cortisone injection done by a radiology company, where there's been no pre-anesthetic, an injection into the base of the heel, no one's going back for a second one. So it's really important, I think, to really make sure the patients had a chance to answer all their questions, but also as a clinician to make sure that I've covered everything that I want to. Now's the time. I've got some contact details. So if anybody has any questions, please feel free to shoot me an email. My email's up there. My LinkedIn, you'll find me by just searching my name. But yeah, please, if you've got any questions, feel free to either connect with me on LinkedIn or shoot me an email. I'm always happy to answer any questions.